Sir, we are live now.
Right. So a very good evening to all. It's my proud privilege to welcome you all, Honorable President of the Royal College of Physicians and Surgeons of Glasgow, Professor Hani Etiba, Honorable President of the Association of Surgeons of India, Dr. Praveen Suryawanshi, distinguished speakers, Professor UN Dixon of the Glasgow Royal Infirmary, and Professor Chetan Kantaria, GI surgeon from KEM Hospital, Mumbai. Honorable office bearers of ASI and RCPSG, friends, colleagues, registered delegates from across India and neighboring countries of Nepal, Sri Lanka, and Bangladesh. President of the Nepalese College of Surgeons, Dr. Romeo Kansakar, YouTube followers, my fellow anchor, Professor John Camillier Brennan, Vice President of the RCPSG. Thank you all for joining us. At the outset, we would like to congratulate both presidents, the president of the RCPSG and the ASI, for recently taking over the reins of their respective august bodies responsible for shaping the future of a generation of surgeons. Heartiest congratulations to you both. The collaboration between ASI and RCPSG is a recent one. Just over a year from now, during the presidency of Professor Mike McCurdy, who was my mentor and teacher from Glasgow, did we start working on it. I'm delighted to state that in a year's time, we have developed close bonds in collaborating with each other academically, professionally, and in friendship, true to the spirit of the motto of RCPSG, Conjurat Amis, which translates to working together in friendship. This is the fifth in the series of webinars. We have had covering topics of mutual interest and commonality like breast diseases, proctology, and now hepatobiliary diseases. I, as the immediate past president of ASI and international convener of ASI, and also I'm incidentally the Royal College of Surgeons as well, international coordinator, hope that this friendship and the bonhomie between these two giant organizations of ASI and RCPSG continues to flourish and bear fruit for enhancing valuable surgical insights and enhancing expertise. I would now like to introduce the President of the Royal College of Physicians and Surgeons of Glasgow, Professor Hani Etiba. Professor Hani Etiba, a renowned frontline interventional cardiologist, is the current president of the Royal College of Physicians and Surgeons of Glasgow. He has served the college for more than 20 years, most recently as their international director and previously as vice president medical. He has also held posts including president of the Scottish Cardiac Society, an associate medical director of the Golden Jubilee, and honorary professor at the University of Glasgow. Professor Etiba is the first international medical graduate to become president in the college's long history. Originally from Cairo, he studied at Al-Azhar University. I would now request Professor Etiba to address this gathering.
That's very kind of you, and I hugely appreciate the humbling words that you mentioned, and thank you for allowing me to be there. Yes, I'm not a surgeon, but I came through the back door as an interventional cardiologist to join the surgical fraternity. Thank you very much indeed, everyone, and thank you, Prabal Muji, for the kind words and for allowing me to address you here today. I am going to give the platform for the speakers. My role is just to celebrate really the association and friendship, as you rightly said, between the Association of Surgeons of India and the Royal College of Physicians Surgeons of Glasgow. Actually, this is very timely because we in Glasgow here are celebrating 425th anniversary of this college. It's more than 400 years of knowledge, discovery, and innovation. We are a global organization, and we love to share with you that 44% and even plus of our membership is outside the UK. The top country of our global engagement and our global membership is the lovely country of India, which I am always privileged to have been attending at least once a year over the last 5 years, whether this is in the Association of Physicians of India, APICON meeting, and I'm looking forward in joining you in Kolkata at the end of the year for the annual meeting of the Association of Surgeons of India. So with those few words, I would like to say how much we feel privileged that this joint venture between ASI and the Royal College of Physicians and Surgeons of Glasgow has been successful. We're actually replicating that exactly with the Association of Physicians of India, although we are taking much faster steps than the physicians, which is not surprising for the surgeons community. After the success of the 2024 joint webinar program, we are pleased to announce that new series of free webinars in 2025 has been agreed. The topic of this initial webinar is benign biliary obstruction, and the most important part of it, it's a joint venture. It's India and Scotland, Glasgow, and it's an opportunity for our fraternity in India and also in Glasgow to engage, learn, reflect, share knowledge, and exchange expertise, because the days that we are here to teach you something has long gone. We learn from you. We learn from you in clinical, academic, and also in healthcare delivery systems that I am so very much impressed when I come to visit India. With these few thoughts in mind, I'm grateful for this opportunity to address you, and I will pass on to the faculty and the chairs to start the webinar. Thank you.
Thank you, Professor Etiba, for your kind words, and we really look forward to welcoming you at our ASICON annual conference, ASICON in Kolkata, at the end of this year. May I now have the honor of introducing our President of the Association of Surgeons of India, Professor Praveen Suryawanshi. Professor Praveen Suryawanshi is the 83rd President of the Association of Surgeons of India. He is currently the Deputy Dean and Professor and Head of the Department of Hepatopancreatico-Biliary Surgery at the MGM Medical College and Hospitals of Sambhajinagar. He is an advanced laparoscopic, hepatobiliary, and liver transplant surgeon at the Center of Excellence for Gastroenterology and Minimal Access Surgery, having performed the first liver transplantation in Central and East Maharashtra. Not only is he an advanced laparoscopic surgeon, but also one of the few surgeons in India performing a variety of advanced endoscopic procedures as a surgeon. He is the Chief Executive Officer of the MGM Medical Center and Research Institute. He is the founder president of the Marathwada Hospital Association and chairman of the Zonal Transplant Coordination Committee. He has innumerable awards and fellowships to his credit and is an astute teacher and philanthropist, and has been recognized for his work with awards from the Government of India and also many other non-governmental organizations of our country. Over to Dr. Praveen Suryawanshi.
Thank you so much, Prabal, for these kind words. Again, I, as a President of Association of Surgeons of India, wholeheartedly welcome all the guests, faculties, and dear viewers. As mentioned by Dr. Prabal, and I'm very happy to mention that this joint venture between ASI and Royal College of Physicians and Surgeons, Glasgow, was started during Prabal's period. And the things which were initially thought has grown into a big tree. And I'm very happy to mention that today we have more than 1,500 registration, which first time we have crossed 1,500 in last 4 series. So it shows that the many young graduates and surgeons practicing in India and neighboring countries, they are really looking forward for such a joint webinars, especially in the gray areas of surgeries, where there is no clear-cut guidelines, but the knowledge and the wisdom of these international faculties, they can definitely throw some light and guide this young generation. So that's why we have selected this topic today. And I'm very happy to, be a part of this topic, because I myself, being a hepatopancreatic surgeon, is very close to my heart. And I'm very, excited to, witness these excellent lectures from the masters in the field by Dr. Ian Dixon and Chetan Kantaria. So, with as mentioned by Annie, that we are really excited to collaborate in more and more, areas in the surgical training, whether it's a webinars or the faculty exchange program or the student exchange program. So definitely with your suggestions and guidance, we'll explore all these areas where we can have more and more collaboration. And this, whatever we have started with webinars, will go a long way in the different areas also. So I really congratulate Dr. Prabal Levgia, our international convener, for taking all these efforts and making it such a successful program. And I'm sure with all same enthusiasm in future, we'll have more and more such a successful program in future also. So once again, I welcome all the faculties and all the delegates and viewers for this first this year webinar, jointly hosted by RCPSG Glasgow and ASI. Thank you so much.
Thank you, Praveen, for the encouraging words. And I'm sure we will take this, I promise you that we will take this up even further to higher levels. So now let's get going with our first speaker, Professor Chetan Kantaria, who's a surgical gastroenterologist. And he's a professor and head in charge of the liver transplant program in the Department of Surgical Gastroenterology in one of the top institutes of our country, the KEM Hospital, Mumbai. He's a Commonwealth Fellow and HPB and liver transplant surgery from Birmingham, UK. And he's a fellow in the advanced course in medical education. He's an eminent medical teacher with an N by awardee. He's a president-elect also of the Indian chapter of IHPBA. Over to Professor Kantaria.
Thank you so very much. I'll start sharing my slides. So, respected Professor Henry Etiba, President of Royal College of Physicians and Surgeons of Glasgow, respected Dr. Praveen, President ASI, my fellow speaker, Mr. Ewan Dixon, Professor Prabal Niyogi, the international convener and immediate past president, Mr. John Brennan, Mr. Romeo from Nepal, the other distinguished colleagues from both the sides of countries, and our viewers, a warm welcome from India and ASI. And the topic of my today's discussion is going to be an update on choledocholithiasis. So, if I were to introduce choledocholithiasis and its incidence, I would say that around 10 to 15% of patients undergoing cholecystectomy for uncomplicated symptomatic choledocholithiasis, they are found to have choledocholithiasis. And this choledocholithiasis could be either primary or secondary. As far as their management is concerned, there are several options which are available, though ideal management of the concomitant stones in gallbladder and CVD remains controversial. So as far as classification is concerned, it can be called as a primary choledocholithiasis in absence of gallbladder, and this criteria have been very well laid down by Professor Saharia in 1977. So these criteria are that there is to be history of previous cholecystectomy, followed by a period of at least 2 years of being asymptomatic. The stone should have features of stasis stones, that is soft, light brown, easily crushable, and often sludge-like. There should be no evidence of long cystic duct remnant, and there should be no evidence of stricture resulting from primary biliary tract surgery. In patients who have gallbladder in situ, the primary choledocholithiasis can arise de novo within the bile duct, either intrahepatically or within common bile duct. It is more commonly seen in Asian population, and when it is intrahepatic stones in origin, it is usually complicated by recurrent pyogenic cholangitis. Secondary choledocholithiasis are the ones which are usually more commonly encountered. They originate in gallbladder and then they traverse to CBD by means of cystic duct. The exact factor that promote migration of secondary gallstones, though, is not very clear. As per Taylor and Armstrong, cystic duct with a diameter of less than 4 millimeters, the chances of migration are only 3%, whereas if the cystic duct diameter is more than 4 millimeters, then the chances of it migrating is as high as 33%. It is usually seen that these stones develop in obese females more than 40 years and who are on OC pills. So this is a pictorial representation of how secondary stones develop. So they may develop either in the within the liver and traverse down, or they may traverse down within the gallbladder. Now the characteristics of the primary CBD calculi are they're usually brownish yellow with muddy consistency. They are composed of calcium bilirubinate mixed with variable amounts of cholesterol and calcium salts. They usually result from bacterial infections in bile ducts, and this is usually attributed to bile stasis, which may be due to the sphincter of Oddi dysfunction. So this is a representation of a primary CBD calculi, whereas secondary calculi, the composition is that of a gallstone because they usually traverse from there. So therefore, they are more predominantly cholesterol stones with mixed composition, though the black pigmented stones can also occur. These stones are often a sign of chronic extravascular hemolytic anemia, whereby excess bilirubin in the bile resulting from hemolysis produces calcium. So these are the examples of a secondary calculi which are predominantly cholesterol stones. As far as clinical features are concerned, these patients usually present with pain, which is colicky, either in the right epicondrium or in the epigastrium, which is moderate in severity, intermittent, and recurrent. They may have jaundice, which may manifest as yellowish discoloration of eyes and skin with pruritus, and in late stage, they may have clay-colored stools, and patients usually come initially saying that their urine is turning tea-colored, and this jaundice can occur in episodes. And besides this, they may have nausea and vomiting. Occasionally, when it gets complicated because of the infection ascending cholangitis, then these patients may present with Charcot striates, where there is pain, fever, and jaundice. And in very severe cases, when there is accompanying hypertension and mental obtundation, it is what called as a Reynolds penta. It's not very uncommon for these patients to present with biliary pancreatitis following CBD obstruction due to calculi at the level of ampulla of Vater. So these patients present with pancreatic pain, which is epigastric or mid-abdominal region. It is continuous as compared to a colicky pain in choledocholithiasis, and it classically radiates to back. They also have nausea and vomiting, and occasionally, when there is transient blockage within CBD due to floating stones or debris within CBD, it can give rise to intermittent pain. So this is how the stones from the bile duct traverses down, gets lodged at the ampulla, giving rise to biliary pancreatitis. So it's very important to differentiate choledocholithiasis from a distal cholangiocarcinoma or a bile duct cancer, Klatskin's tumor, bile duct stricture, choledochal cyst, and occasionally peptic ulcer disease, acute cholecystitis, sphincter of Oddi dysfunction, and functional gallbladder disorder. Now, as far as the evaluation is concerned, the American Society of Gastrointestinal Endoscopy, based on age, symptoms, liver biochemical test, and USG findings, they have proposed a model for probability of choledocholithiasis, wherein they stratify it as low, where the incidence is less than 10%, intermediate, 10 to 50%, and high risk, that is more than 50%. So how does one evaluate this patient? So the first and foremost is hemoglobin, WBC, and platelets. So if it's because of hemolytic anemia, you expect the hemoglobin to be low. In cases of cholangitis, the WBC is raised. LFT, liver function test, where there is increase in both total and direct hyperbilirubinemia. So if the obstruction is persistent, then the bilirubin usually increases to 3 to 4 milligrams, which strongly suggests association with CBD calculi. Here it is very important to note that if the bilirubin is more than 10 to 15, then it is unlikely to be due to stone disease and you have to strongly suspect malignancy. Alkaline phosphatase usually increases late in the clinical phase. SGOT, SGPT may be elevated, but again important to note that gamma GT exceeds more than SGOT, SGPT. And it's important to PTI at a prothrombin time and INR because you may be doing some intervention. What imaging do you do? So the first and foremost imaging when the patient presents with symptoms is ultrasonography of the abdomen. So this is the initial imaging study where you can see echogenic shadows around with acoustic shadowing. Though the limitation of this study is that the distal CBD is very difficult to evaluate because of the overlying bowel gas, but you can definitely detect a dilated extrahepatic biliary duct. Usually the bile duct is increased in size to around more than 6 millimeters, and this has a sensitivity of 73% and specificity of 91%. Next is CECT scan. Now, let me make it very clear that CECT scan is not the investigation of choice for choledocholithiasis. You do it only if there is a strong suspicion of underlying malignancy. The signs on CECT scan, which are suggestive of choledocholithiasis, are target sign, where there is a central round density because of the stone, and surrounding it is low attenuating bile or mucosa. Then there is a rim sign where the stone is outlined by a thin rim of high density bile. Crescent sign where the bile eccentrically outlines the luminal stone, creating a low attenuation crescent. And in 20% of patients, you will get calcification of the stone. Again, as I said, that this is not the investigation for choice for choledocholithiasis, and its sensitivity is very low, as low as 65 to 88%. So here you see that there is a small calcification seen suggestive of calculi, and same is seen in the sagittal. Next investigation of choice is MRCP. It is supposed to be the gold standard as far as making a diagnosis of choledocholithiasis is concerned. And it is recommended in patients who have intermediate probability of having choledocholithiasis. Its sensitivity is as high as 90 to 94% with specificity of almost 100%. So this is a representative MRCP where you see the presence of calculi in the distal CGD. Next, we come to endoscopic ultrasonography. So this is a first option for evaluating a patient with an intermediate probability of having choledocholithiasis. The USP of this investigation is that it is not limited by bowel gas, and it scores over MRCP in the fact that it can detect non-floating stones in the papillary region, small stones as small as 5 millimeters or less than that, and it helps in defining the size and number of stones. Its sensitivity is 95% and specificity is 97%. So these are the representative images of EUS, where here you see EUS done from the gastric body showing two distal CBD stones. Your US is done, seen from the mid-second part of the duodenum, where a large impacted calculi is seen. And this is a small, soft, non-shadowing CBD stone from the bulb of the duodenum. Next is ERCP. So ERCP is usually done when you have a very high probability of CBD stone. If you are very sure that CBD stone is there, only then you would do an ERCP. And this is the reason for this is because it is essentially therapeutic, and besides it being invasive. So ERCP is a treatment of choice in patients who present with CBD stones post cholecystectomy, or patients who present with acute cholangitis when you want to decompress the bile duct, or patients who have acute pancreatitis with persistent biliary obstruction when it should be done within first 48 to 72 hours. Now coming to the management of choledocholithiasis. So if the stone has been diagnosed preoperatively on investigations, you could do either a two-stage procedure of preoperative ERCP followed by laparoscopic cholecystectomy, or you can do a one-stage procedure of laparoscopic cholecystectomy followed by laparoscopic bile duct exploration, or a one-stage procedure of laparoscopic cholecystectomy with intraoperative ERCP, or you could do a two-stage procedure again, that is laparoscopic cholecystectomy followed by post-operative ERCP after 48 to 72 hours. Or in some cases, you would do an open cholecystectomy with open CBD exploration. So let us see each in detail. So coming to preoperative ERCP stone extraction followed by laparoscopic cholecystectomy. Until the last decade, this was the standard of care for patients who presented with gallstones and CBD calculi, wherein you did an ERCP and then subjected to patient to lap choly either within 72 hours or if not, then after 2 weeks. However, the drawback of this particular approach is that it requires repeated hospitalization, prolonged hospital stay if it is done within 72 hours. There is risk of repeated anesthesia both for ERCP as well as for lap call. And if the patient has not been stented, then in the period between ERCP and laparoscopic cholecystectomy, there is a risk of stone migrating into the CBD again or a recurrence of cholecystitis. And most important is that it increases the overall medical cost. Having said that, it still is the procedure of choice in patients with advanced age or a patient with poor general health who cannot tolerate a prolonged anesthesia, in whom a two-staged approach is preferable than a one-stage approach. Now, coming to the next procedure, that is a single-stage laparoscopic cholecystectomy with laparoscopic bile duct exploration. So the indication is when you have detected the stone preoperatively or on intraoperatively, you have a suspicion, you do an intraoperative imaging in form of laparoscopic ultrasonography and confirm there is a stone, then you would do this approach. Or if the patient has an altered anatomy, making ERCP difficult, as for example, patient who has undergone a Roux-en-Y gastric bypass previously. As far as contraindication is concerned, there are no definite contraindications for these procedures. There are relative contraindications, that being hemodynamic instability, hostile portahepatis intraoperatively, and lack of technical skill or resources in form of equipment, personnel, but these are all soft contraindications. What is important is for this procedure to be followed, you should be good in doing intraoperative cholangiography, or you should have a facility of laparoscopic ultrasonography available with you. Now, you could do this laparoscopic bile duct exploration either transcystic or transcholedochal. So Petlin et al. Have very nicely given a good chart where they have helped us that which procedure should be done when. So when you have whether you have a single stone or multiple stones, you could do either of the approach. If the stone is less than 6 millimeters in diameter, you can do again either of the approach. But if the stone is more than 6 millimeters in diameters, then you have no option but to do a transcholedochal. If there are intrahepatic stones as well, then you have to do transcholedochal. If the diameter of cystic duct is less than 4 millimeters, then you cannot do transcystic, you have to do transcholedochal. But if the diameter of cystic duct is more than 4 millimeters, you can do either of the approach. If the diameter of common bile duct is less than 6 millimeters, then you have no option but to do a transcystic approach. If the diameter is more than 6 millimeters, you can do either. Now coming to in what position does the cystic duct enter this bile duct? So if it enters laterally, which is most commonly seen, then you can do either of the approach. But if it enters posteriorly, then you have no option but to do transcholedochal, because transcystic is going to be technically very difficult. And so is when it enters distally, when it opens just at the termination of the bile duct near the duodenum, then again you would like to do a transcholedochal. You would not do this procedure if there is marked inflammation, and you should not venture into doing a laparoscopic bile duct exploration if your suturing ability is not very good. So this is with regards to approaches of laparoscopic CBD exploration. Now we come to single stage intraoperative ERCP along with laparoscopic cholecystectomy. It's the upcoming modality. It combines the benefits of both single and two-stage procedures. However, this facility of having ERCP in the operative suite is not available everywhere. It requires great expertise to do this. And most importantly, this procedure, this approach mandates a high degree of cooperation between the surgeons and endoscopists, which is really a challenge at many of the places. So single stage intraoperative ERCP along with laparoscopic cholecystectomy, other than that, the limitations are that this may require conversion intraoperatively, either due to inability to complete cholecystectomy laparoscopically, when you will have to convert it to open, or if you fail to extract CBD stone via ERCP, then you will have to do a laparoscopic bile duct exploration. Besides this, following ERCP, there occurs a great amount of bowel distension, which makes, because of the insufflation, which makes laparoscopic cholecystectomy very challenging and tests the skill of the surgeon. Also, post-ERCP pancreatitis is not very uncommon, and this could actually prolong the patient's recovery and hospital stay, adding to the cost. Next, we come to laparoscopic cholecystectomy and followed by post-operative ERCP. This procedure is for theoretical mention. It is not preferred and not practiced by almost everybody. Because this entails a second surgery if you fail to retrieve the stone through ERCP following surgery. Besides this, you have done a laparoscopic cholecystectomy, you applied clips, and if you insufflate, there is a risk of cystic duct blowout with bile leak. And besides this, it's technically difficult. So this procedure is actually a no-no and not done by almost universally not done by all. Now, if I were to compare all the procedures with each other and find out which is the best, to help me this, I have taken into consideration this recent article published in Journals of Clinical Gastroenterology, where they have compared the three procedures. So it's a retrospective study where they have divided the patients into three arms. The first arm is conventional ERCP followed by a laparoscopic cholecystectomy, that is two-stage procedure. Then laparoscopic ERCP intraoperatively, that is one-stage procedure, and laparoscopic cholecystectomy with laparoscopic bile duct exploration. So they took into consideration stone clearance, conversion to other procedures, mortality, operative time, length of hospital, and cost effectiveness into consideration. And when they compared statistically, they found that between group 1 and group 2, there was not much statistical significance. Again, between group 1, however, between group 1 and group 3, and group 2 and group 3, there was a great statistical significance favoring laparoscopic cholecystectomy with laparoscopic bile duct, common bile duct exploration. They also took into account post-operative biochemical investigations, including ALT, AST, bilirubin, and amylase, and they found that there was not much significance or not much to choose from between the three procedures. When they took into account short-term complications, that is bile, bleeding, pancreatitis, wound infection, duodenal perforation, again, they found that there was not much to select. It was almost the same in all the three groups. But when it came to long-term complications, that is 4 to 5 years after treatment, where they took into consideration biliary stricture, recurrent common bile duct stones, and CBD cancer, they found that compared to when they compared group 1 to group 2, they found that there was not much statistical significance, but they compared each procedure to the laparoscopic bile duct exploration, they found there was a greater statistical significance favoring again laparoscopic cholecystectomy with simultaneous laparoscopic common bile duct exploration. So concluding concluding the comparison, they said that though both 1-stage and 2-stage management of common bile duct stones are efficient therapeutic options, when it comes to laparoscopic cholecystectomy with simultaneous laparoscopic bile duct exploration, it offers a safer therapeutic approach with shorter length of hospital stay and operative time, lower cost, and fewer complications. So based on evidence, this is the treatment of choice if you have the expertise available. Now, finally, coming to open CBD exploration, the indications are when there is a failed or complicated endoscopic methods, where you fail to retrieve the stones preoperatively through ERCP, or if it's a large or difficult stones, impacted stones, making the removal through ERCP very difficult, or if there is a lack of endoscopic access in peripheral centers, then you have no option but to do an open CBD exploration for this. So I would not go into details. What is important is that you should do an adequate mobilization of duodenum, choledochotomy, you retrieve the stones with Desjardins forceps, ensure its clearance by sweeping in with balloon catheters. If you have facility for choledocoscope, you do that. And if a prior sphincterotomy has been done, you can suture it directly, or you could suture it over T-tube. Alternatively, if you are not very sure, if there are multiple calculi, and if you are not very sure that whether it has been adequately, completely cleared of these stones or not, then you could do a choledochoduodenoscopy. So the caveat for doing choledochoduodenoscopy, however, is that the CBD diameter should be more than 1.5 centimeters, and there should be no duodenal pathology. So what you do is you take an incision along the line of axis of duodenum, and you take a vertical incision, you do choledochotomy, you create a diamond, and you suture it like this. As you see, the posterior walls have been taken. You suture it, taking interrupted sutures with foro EDS. So as far as the management of choledocholithiasis post-diagnosed intraoperatively, then as I said, you have an option of doing laparoscopic cholecystectomy with simultaneously laparoscopic bile duct exploration. You could do a laparoscopic cholecystectomy with intraoperative ERCP. You could do a post-operative ERCP, or you could do an open cholecystectomy with open CBD exploration. And finally, stones, patients who have been operated before and they come back with pain 3 to 4 months later on, then you have no option but to do a post-operative ERCP. If you are not successful in retrieving the calculi, then you could do a CBD exploration, either laparoscopic or open. So I would like to end by showing an algorithm, which is actually a summary of what I have said, that if a stone has been diagnosed preoperatively, you could do either a surgical lap poly with laparoscopic bile duct exploration, or ERCP followed by lap poly. If it is diagnosed intraoperatively, then you can again do a lap poly with lap bile duct exploration, or you could do a lap poly with ERCP. And if it is diagnosed post-operatively, then you do an ERCP with retrieval. If unsuccessful, then you do a surgical bile duct exploration. So thank you very much for patient hearing, and I'm happy to take any questions on this.
John, please.
Thank you very much for that very informative presentation. May I now introduce Mr. Ewan Dixon. It is my great honor honor to introduce Mr. Dixon, who is a consultant pancreatic surgeon in the regional referral unit for complex pancreatic and biliary surgery at Glasgow Royal Infirmary. He also has a strong interest in emergency care, and after gaining an MD, he undertook a trauma and critical care fellowship at the Johannesburg General Hospital. Mr. Dixon was awarded the ASGBI medal as the outstanding candidate in the final sitting of the FRCS intercollegiate exam in 2006, prior to his appointment to the West of Scotland Pancreatic Unit the following year. His subspecialty practice includes major pancreatic resections, the management of severe acute pancreatitis, and advanced pancreatobiliary endoscopy, including ARCP and EUS. In 2019, he was awarded the prestigious James Default Association of Surgeons Traveling Fellowship, one of the most prestigious international awards for surgeons. The primary focus of this fellowship was the management of borderline resectable pancreatic cancer. Mr. Dixon's academic, teaching, and research interests are in pancreatic surgery, trauma, enhanced recovery after surgery, and perioperative care. He has lectured and taught extensively in these fields and continues to publish and author book chapters on these subjects. He is the national lead for hepatobiliary surgery and lead clinician for surgical critical care and the pancreatic ERAS program. Over to Mr. Dixon. Thank you.
John, thank you very much for the very kind invitation, and also thanks to the Glasgow College and to the ASI for the invitation. It's a real pleasure to be involved. I'd like to start also by thanking Dr. Kantharia for a fantastic talk. It's amazing how much you learn at these meetings where you're supposed to be part of the faculty, but I thought the talk was a fantastic summary and overview. So, as John said, I work in the West of Scotland HPB unit. This is a tertiary referral centre. We cover a population of around 3 million people, and my elective practice is exclusively pancreaticobiliary, so I don't do any liver work. But instead of that, we do all the Whipple resections, we manage the complex benign disease such as severe acute or chronic pancreatitis. And unusually for a surgeon, I do ERCP and EUS. And as part of this practice, we obviously manage benign biliary disease, including strictures as well. If any of you have been to Glasgow, you'll appreciate that there is no shortage of substrate for pancreatic and biliary disease where I work. But it's not all caused by alcohol. We do have some stone-related disease as well. When you're looking at benign biliary stricture management, you can break it into two parts. There's the decision-making and the practical skills. And I think particularly when we're training or we're new consultants, we get very focused on the practical skills. But actually the hardest part with all of HPB, and in particular benign biliary stricture management, I think is the decision-making. And the biggest challenge is trying to work out whether you should intervene, and if so, how should you intervene, rather than in the skill itself. So if you look at biliary strictures, this is a spectrum of disease, and it's punctuated by a series of critical decision nodes where you get an opportunity to try and do the right thing or perhaps get it wrong. And there's often so much information involved that I think taking a reductionist approach is very helpful. And the key to decision making is to answer two questions. One, do I need to intervene? And if the answer to that is yes, how am I going to intervene? And the answer to these questions is governed by the timing. Is it early or late in the disease course? In particular, patient physiology, which I'll come back to again, and the anatomy, what's achievable and which routes do you have to try and intervene for this patient? So the keys to success, I think, are meticulous attention to detail within an MDT, and the MDT part is critical. Decision-making with a flexible mindset where it's okay to change your mind or do a U-turn or try something different. And to think about the patients as individuals, so it's individualized multimodal therapy rather than one size fits all. And it's really about getting your ducks in a row. So the aims of this talk are to offer my practical take for the person on the spot in this evolving area, accepting that as this talk finishes, it's likely to be out of date because things move on so quickly. Second thing is to look at a systematic approach with an overview of the techniques. I'm specifically not going to try and tell you anything that you could Google, but try and keep it as pragmatic as possible for the person on the spot. And in typical surgical fashion, I'm going to offer you anecdote, opinion, bias, and unsubstantiated surgical dogma. The first thing you have to do, I think, is define the problem. So benign biliary strictures, by definition, are non-malignant narrowings or complete obstruction of the biliary tree. They may be isolated or they may be multifocal. They may be intrahepatic, extrahepatic, or both. And they may be luminal, mural, or extramural. The biliary system is just a cylinder. You can have a problem in the cylinder, in the wall of the cylinder, or outside the cylinder. So I think you have to define the problem first of all. The second part, which is probably even more important, is to understand your goals before you even start to manage this patient. And there are 4 principal goals. The first goal is to relieve biliary obstruction if the benefit outweighs the risk. And that's really important because intervention is not required for all biliary strictures. And given that there are no zero risk biliary interventions, make sure that what you're going to do is of more benefit than harm to the patient. And that can be a difficult judgment call. The second thing is to try and maintain long-term drainage, and that part is critical as well, because unlike, sadly, in many of the HPB malignancy cases where the techniques outlast the patients, with benign biliary strictures, this is a problem that you and the patient may have for many years or decades. Preserve parenchymal function or preserve liver function, and crucially address coexisting issues such as sepsis. So you have 4 goals: relieve obstruction, durable drainage, preserve liver function, and address sepsis or other coexisting problems. So these are the goals you have to work out at the start. You can Google etiology, so I'll keep it brief, but there are 2 I's and an O. There's injury, for example, post-lap chole. There's inflammatory, commonly for us, that would be recurrent cholangitis secondary to stone disease or PSC. Could be pancreatitis, that's an example of the extraluminal compression, either by a large pancreatic acute collection or chronic pancreatitis. And then the O is other, for example, Meritzi syndrome or ischemic cholangiopathy. One of the key points to bring up against here is that although this talks about benign biliary strictures, that presupposes that you know it's benign. And one of the hardest things in medicine and particularly in HPB surgery is trying to disprove cancer, which is rarely possible. So differentiating what you think is a benign stricture from a malignant stricture can be really challenging. Presentation typically involves a few things: abdominal pain, jaundice with obstructive features such as dark urine and pale stool. You may have systemic upset such as rigors or fevers, itch, and weight loss. But it typically involves pain, usually but not always involves jaundice, and may involve fever. The initial management, I think, is the same for all of these patients, and physiology always trumps anatomy. So you deal with this first. So regardless of the nature of the stricture, if you have a stricture causing jaundice and with that you have sepsis, coagulopathy, renal dysfunction, physiology always comes first. Surgeons don't like that because we tend to think of anatomy, but it's all about physiology. You don't need to know granular detail at this stage. You don't have to know the exact diagnosis. You just have to know you have biliary obstruction. And therefore, the initial management, I think, in terms of taking a reductionist approach, is always the same. The patients may require resuscitation if they come into you acutely and may require adjuncts such as antibiotics if you have coexisting sepsis. When it comes to investigation of what you think is a benign biliary stricture, again, it's fairly straightforward because the basics, I think, are always the same. There's the routine blood tests, observations, the thing that we'd expect to do. But thereafter, I think the hierarchy of tests depends upon your pre-test probability or your clinical suspicion for what you think the problem is. So I usually start with a deal breaker investigation, and for me, that's usually a contrast enhanced CT. Because remember, you won't know it's benign at this stage, and the CT is a great catch-all, and it's often a great reassurogram to tell you, for example, you don't have widespread disease, a pathology you haven't thought of, or a mass, all of which would raise the possibility or spectre of malignant stricture. The next steps, I think, fall into 5 different groups. And again, it comes down to your clinical suspicion. What do you think the problem is? Ultrasound, in my view, is great for stones, and it's good for intrahepatic dilatation. It's less good for the extrahepatic tree. MRCP, as you've heard already, in my view, is the gold standard for biliary tree assessment and for pancreatic duct assessment. EUS, I think the role there for the benign stricture is in the CT negative patient, then EUS can be quite good at ruling out a small associated mass. And again, doing EUS, I find that very helpful to scope the patient and look for a small mass associated with a stricture, which may raise the possibility of cancer rather than benign disease. And it's also good at looking at bile duct wall thickness in the context of cholangiopathy. ERCP, as you've heard from the previous speaker, is rarely the first step. I think it's one of the most dangerous things that we do. It has a mortality, if you really dig deep, approaching that of coronary bypass surgery. So it's not a small day case telescope test. It's almost never used for diagnosis, and it's usually used for therapy when, as again you've heard previously, you've got a high index of suspicion of a problem in the bile duct. And Tmax HIDA or functional nuclear medicine studies I would reserve for when your anatomical studies have been exhausted. When it comes to definitive management, it's all about context. And the aim here is a good, durable fix with the 4 goals that I mentioned to you, not a quick fix. And like most surgical decision making, I just think of the 3 Ps. There's the patient, that's the big picture. That's the thing that's around the bile duct on your scan. There's the physiology, which tells you how urgently you have to do things and what you have to do. And then finally, there's the pathology that's causing the problem in the first place. But that's the 3 Ps of surgical decision making, I think, for almost everything we deal with. So our challenge as surgeons and endoscopists, or both, is to try and recognise the limitations of every technique and every modality. These are often complex patients, they've got competing priorities, and as I said at the start, they usually require an individualised multimodal approach. So know your limitations and know the limitations of the procedure you're planning on doing as well. And the problem that I think many units have, and we're fortunate because we do EUS and surgery and ERCP, is that we can pick the best tool in the box, rather than if your only technique is ERCP or laparoscopy or surgery, then you have a focus sometimes of trying to make that work for everyone. And on that basis, I think it is true when all you have is a hammer, the whole world can look like a nail, and it's very easy, particularly with these kind of strictures, to practice procedure-focused medicine rather than what's best for the patient. And this takes me on to the decision-making for the presumed benign biliary stricture. I think there's an HPB paradox, and I think it holds for pretty much all of HPB medicine and surgery. And that is the decision-making, in my view, is much more complex in the HPB patient with benign disease than in the patient who has suspected or proven HPB malignancy. And there are a couple of reasons for that, but it's particularly true for biliary strictures. And the first one is your options for the management of a biliary stricture are more limited. So for example, PTC with uncovered stenting is often a bad idea for a biliary stricture because you'll never get that out. The second thing is, and if you look at this CT coronal cut I've got up there, you can see this is a patient of mine from a couple of months ago, a dilated bile duct. This is for a distal cholangiocarcinoma, and we did an EUS biliary drainage, so going from D1 into the bile duct. And that's a great tool for malignant disease, but it's not great for benign disease. So your interventional options are more limited. And the second thing to always bear in mind, and it's why you have to keep your 4 goals in mind and really work out what you're planning to do with regard to a good fix and not a quick fix, is that your chosen therapeutic modality has to be much more durable than for the patient who has HPB cancer. And that's sadly and unfortunately because in malignancy with HPB, the technique, such as the stent, often outlasts the patient. So your options are limited and your procedure has to be more durable. Options briefly, medical options, ursodeoxycholic acid, for example, to enhance existing drainage, steroids for autoimmune cholangiopathy, and then I think the more complex options are best managed by a specialist gastroenterologist, such as someone who deals with second-line agents, perhaps as part of IBD work, including tacrolimus or azathioprine. The key point here is that medical therapy is often preferred for multifocal rather than very focal strictures. Endoscopic options, EUS is pretty low risk for diagnosis. It's higher for therapeutic interventions such as the drainage that I showed you, and it's therefore most commonly used to assess strictures, exclude a mass or a stone that you may not have seen on MR. ERCP is high risk however you play it, whether it's diagnostic or therapeutic, and most commonly used in the context of jaundice or coexisting cholangitis, or for brush cytology, or often for remodeling with SEMS. And if I'm doing a SEMS in these patients, you can see in the ERCP picture here, it's a partially covered SEMS. And I think they have the best of both worlds, where their slip rate is less because they've got a bit of exposed wire at either end, but you can actually get them out fairly easily because they're partially covered. And finally, don't forget cholangioscopy, which is really good for stricture assessment or biopsy. So that's a baby scope going down the mother ERCP scope to directly visualize the stricture and perhaps do spy bites or small biopsies. Coming back to the MDT approach, IR options are critical, and it usually takes the form of a PTC. In the benign stricture, I would reserve this for two principal indications. One is when you have a hilar stricture requiring bilobar drainage. I'm not sure that ERC is great for that. And the second is failed endoscopic access. If you are using PTC, then balloon dilatation for the benign stricture is preferred over an uncovered SEMS for benign disease, because it's almost impossible to get these stents out again. And once they start to have stent dysfunction, they're a real challenge. And then surgical options. Surgical options are good if you have failed endotherapy, but they may also be a good first-line durable option in the young patient, and in particular in the patient who has a focal extrahepatic stricture. This diagram shows you an end-to-side hep gedge. I think in the context of benign disease, they're often better with a side-to-side hepatojejunostomy if you can do that, because it then gives you the option of further attempts at ERCP or endo access if required. So try and preserve your endoscopic access. Remember that hepatojejunostomy has its own stricture risk, and also in the context of benign stricture disease, particularly for multifocal disease, remember liver transplantation and discuss that early with your regional centre. In the context of cholangitis for the benign biliary stricture, sepsis changes everything, and your focus shifts from diagnosis first to therapeutic first. You can see pus coming out of the bile duct here at an ERCP. Choose your simplest option, take a very reductionist approach. Your only goal now is biliary drainage. Deal with the physiology. You can deal with everything else later, and everything else can wait. So in summary, the take-home messages that I would offer are: step one is to define the problem. Is it intra or extrahepatic? Is it single or multifocal? Because these crucial questions inform and help you make decisions about your options. Understand your goals. There are 4 goals: relieve obstruction, achieve durable drainage, preserve liver or parenchymal function, and address other issues such as coexisting sepsis. Management for the benign biliary stricture, like every surgical issue in my view, is governed by the 3 Ps. That's patient, physiology, and pathology. The initial management is almost always the same, and for me usually includes a contrast-enhanced CT as a reassurogram to try and exclude a mass or metastatic disease. You choose your next investigation, whether it's ultrasound or MR, and so on, depending on your clinical suspicion. What's your pre-test probability? Worth remembering that you don't have to intervene for every biliary stricture. You do it based on risk versus benefit. If you do intervene, think about that risk versus benefit. And this decision-making, I think, is much more complex in the benign HBV patient than the cancer HBV patient for the reasons I've covered previously. Your options include medical therapy, perhaps with your specialist gastroenterology colleagues, endoscopic therapy broken into EUS, ERCP, and cholangioscopy. Our IR colleagues have a large role to play, and then surgery. Cholangitis or sepsis changes everything. Sepsis management is now your priority. Everything else, including a diagnosis, can wait. And although this talk has been really about benign biliary strictures, remember that in this context, you can never disprove cancer. Thank you all very much for your time.
Thank you very much, Ewan, for that excellent presentation. And we shall now open the floor to questions. So I'm looking at our chat box here, and the first question is by Dr. Firoz Khan. What is the incidence of cholangitis after ERCP and choledochoduodenostomy? Maybe you can start, Ewan.
Yeah, it's a good question. I think the incidence of cholangitis after ERCP is pretty low because you're usually doing it for biliary obstruction. In fact, I think the days of diagnostic ERCP have well and truly gone. They've been replaced by MR and EUS, which are much safer. So you're almost always doing, by definition, an ERCP for biliary obstruction. And if your goal is to relieve biliary obstruction either through stenting or removing stones, then the incidence of cholangitis after that, I think, is very low. So it's not a major concern or consideration for me as an ERCPist.
Is there any specific way we could minimize such a risk?
Yeah, we used to give antibiotics routinely for ERCP. We don't do that anymore. And the patient who has pre-existing cholangitis, i.e. you're doing the ERCP for cholangitis, I tend to keep the antibiotics running before and often afterwards for a day or two to ensure I've got decent drainage. And on that note, one of the ways of minimizing your risk of post-procedural cholangitis is to ensure you have adequate drainage. The danger with the ERCP is trying to do too much. And all you need is a stent and a bile duct to ensure you get decent drainage. It's when you try and get too clever about it and try and remove multiple stones or leave stones behind, that's when you get into trouble.
Okay. Thank you. Dr. Kantare, would you like to add anything else to that answer?
So basically, as far as ERCP risk for cholangitis is concerned, the risk increases when there is difficulty in cannulation. A number of attempts, each attempt you make, it increases the risk further. And as far as the question was that what is the risk associated with choledochoduodenostomy, there is again the risk is very, very low as far as cholangitis following choledochoduodenostomy is concerned. We have never encountered, we do quite a few of them.
Thank you. And as a follow-on for that question, Dr. Ram asked you, is there any role for transduodenal sphincterotomy in gallstone in choledocholithiasis?
So transduodenal means if you do an ERCP sphincterotomy, that would be good rather than doing a surgical transduodenal sphincterotomy. If at all you have to do, you do a wide sphincterotomy, and that would ensure that all these small calculi will get taken care of. But again, that depends upon what type of stones you are dealing with. If you determine that preoperatively based on imaging, that if the stones are very large, then it is not a good idea to do a transduodenal sphincterotomy alone. So that is not going to work.
Okay.
Yeah.
Yes, Prabal?
No, it's fine. Carry on. Yeah. The next question, I think, is from Shikha Singh, Dr. Shikha Singh. Post PBD without biliary tree dilatation, the rapid increase in total and direct bilirubin is suggestive of biliovenous fistula. How can they be prevented? So probably, I don't know. I'm not able to get what she means by that. Post biliary drainage without biliary tree dilatation. There's a rapid increase in total and direct bilirubin. Sorry, the question is not very clear. How many times ERCP fails or is difficult for large stones? Is there any criteria or study where we can straightforward go to open chole and choledocholithiasis?
So basically, if you ask a pure endoscopist, they would never say that we would not do ERCP or a particular type of stone. But generally, if the stone is a giant stone, if it's a impacted calculi more than 5 centimeters in size, they usually get, because it forms a sludge ball, then it's going to be very difficult to be retrieved through ERCP. So in that case, doing an upfront open CBD exploration with choledochoduodenostomy is justified.
A question from UN. How do you manage a multifocal benign biliary stricture?
Yeah, with difficulty and with the gastroenterology colleagues, usually. We have these patients referred to us not infrequently, usually because they present with jaundice and they have an abnormal CT or MR. And the three things I would say in that patient are one, don't rush to intervene in the context of multifocal stricturing. If you start doing things like ERCP and you inject contrast into undrained segments, you're going to have intrahepatic sepsis, which can be really difficult to deal with. Second thing is make sure you discuss this through the MDT, where you review all the imaging and go over the patient's care before you think about intervention. And the third thing is this is a truly multidisciplinary endeavour where you should have your specialist gastro colleagues involved as well, because usually your treatment there is going to start with medical therapy depending upon the context. The exception to all of that would be if you have minimal multifocal stricturing and one dominant extrahepatic stricture, then it's not unreasonable sometimes in that context when you have a jaundice patient to address that stricture endoscopically. And I prefer partially covered SEMS over balloon dilatation. I think they give you a more controlled and sustained dilatation, and they can often help you with remodeling of the duct whilst ensuring biliary drainage at the time the stent's placed.
Right. We have quite a few HPB surgeons here on this panel right now, with Dr. Praveen Suryawanshi, who's doing both laparoscopic and endoscopy, Dr. Puneet and Dr. Romeo from Nepal. They're all hepatobiliary surgeons. If you have any questions, you can put them for the benefit of all of us and for the observers.
I want to know the opinion of Dixon, exactly how he deals with the hilar stricture particularly, and do you have any experience with the transhepatic stents placed preoperatively to help to deal with these strictures?
That was for Ewan, right? Ewan, could you repeat the question? Have you got the question, Ewan? Or?
I didn't catch all of it. I just caught the first part, thanks. If we could just repeat that, Puneet, thank you.
What's your experience regarding the transhepatic preoperative, you can say, catheter placement, particularly in a patient with a hilar stricture, E4 type?
Yeah, so this is for a cancer.
No, for the benign disease.
For the benign disease.
For the post-cholecystectomy stricture.
Yeah, so these are a challenge again, because trying to get adequate and durable drainage is difficult. For a true hilar stricture, so you've got intra and extrahepatic dilatation, then we would often go to our IR colleagues first of all. And again, I think less is more. So we would try and get bilobar biliary drainage with an internal external stent on each side, or drain on each side. We would rarely use ERCP in that context. If you come from below and you don't get adequate drainage of every segment in the liver, I think you just introduce infection and get intrahepatic sepsis. So our algorithm would be bilobar drainage with IR, reassessment. If we think there's an option for dilating or anything else we can do with IR, we would do that. And failing that, then I think you're often looking at an early surgical option. Where you do get into trouble with IR and endoscopy is in persisting when you should have changed a surgical option earlier. And knowing when to do that can be a real challenge.
Yeah. Anyone else?
Dr. Dixon, yeah. Sometimes, as you have already emphasized, that it's very difficult to differentiate between a benign or a malignant stricture. But what would be your investigation of choice, and how would you proceed if there is difficulty in differentiating these two?
Great question. I think that's one of the hardest things we do in HPB surgery. Whether it's a pancreatic lesion or a bile duct lesion, trying to work out what's a cancer versus what's benign disease is a challenge. So the first thing is clinical context. If you have a very high bilirubin in a patient with weight loss or other significant red flag symptoms, then you have to be thinking about, I think your default position is always you have to try and demonstrate this isn't a cancer rather than I think this is benign. So your default is to try and assume it's cancer and then work back from that. CT is great for looking for a mass. MRI to give you duct morphology is helpful. And then, as I mentioned, if we have what we think is a benign biliary stricture, particularly extrahepatic stricture, we almost always do EUS for these patients, because where you do get caught out is with the CT mass negative cholangiocarcinoma, which on EUS you actually see a small mass that you can then, or mass that you can then either FNB or resect. So I guess the short answer is clinical suspicion and red flags, MR and CT as the first steps, and then if you're going down the route of thinking it's benign, do an EUS. The problem with things like ERCP and brush cytology is that you can't disprove cancer. So a positive brush is great, but a negative brush doesn't mean that you don't have cancer.
Yeah, you and I loved your CT assurogram that you mentioned. I think that's the best test to start off with. The other thing is, how often do you use a spyglass for diagnosing a benign or a biliary stricture?
Yeah, so we're using it more and more now. Most of our spyglass work, or most of the spyglass work that I do is for stone burden. So patients who, like you saw in my first couple of slides, your average West of Scotland patient who may not have a great performance status and in whom surgery is not great for stone disease. So we do shockwave lithotripsy or sphincteroplasties and so on to manage that. In terms of stricture assessment, we don't do as much of that, but that's an evolving part of our practice. And I think it has a role. If you do a direct biopsy of the stricture with a little bite that you can get down the scope and it comes back as a cancer, that's great. But again, going back to my original point, you can't disprove cancer. So a negative, what you think might be a benign biliary stricture has to be always contextualized with the big picture of what's going on with the patient.
So could I add
Please,
to the
please.
previous thing? So the question to which Mr. Romeo asked, so these are usually called as indeterminate biliary strictures because in spite of all the investigations, you have not been able to prove what it is. So, and in this case, the suspicion of malignancy should be very high, taking into consideration, as Mr. Dixon said, the patient's age, the symptomatology, and the bilirubin level. And you would like to err it in favor of malignancy rather than keeping it as benign for hilar strictures.
Yeah, I would come back in there and echo that. I think that's a really good point, and I think it holds for every stricture in the GI in the biliary tract. And on that note, if you have a patient with the right age, with a cancer bilirubin, with red flags, with concerning morphology on imaging, and you have negative cytology or pathology, these are patients we would often still offer resection. If you're concerned they have an extrahepatic biliary cancer, then we're quite happy to go to Whipple resection in these patients rather than trying to disprove cancer over many months and miss the boat. So I think it's a really good point.
Can I just, there are a few more questions that have just come up. Can somebody of you take it? These are the last few questions which need to be answered. Dr. Ajay Ahalwat asks, management of post-hip AJ biliary obstruction. What are the diagnostic and therapeutic modalities? Post-AJ biliary obstruction, hepatogenostomy.
Yeah, that again is a challenge because by definition you don't have endoscopic access unless you've done a side to side, and that's done less frequently these days. So in that group, it's almost always IR in our institution, and it's usually, if they're unwell in any way, leave a drain in the first instance, let their jaundice and so on settle, and then it would be balloon dilatation would be the next step. If balloon dilatation fails and you have a fit enough patient who needs a more durable solution, then sometimes you have to go down the route of revisional surgery. The one time we sometimes see HJ issues or what looks like an HJ issue after a Whipple resection is when you have obstruction of the pull-up. And so where the small bowel, for example, goes through the transverse mesocolon, if you get recurrent disease there, you get obstruction of the jejunal limb that the pancreas and bile duct are draining into, then they often present with what you think is an HJ obstruction, which is pain and jaundice. And in that group, we've had some success in doing a gastro to jej limb EUS axius drainage to decompress them and let them move on to palliative chemotherapy.
Yeah. Now this is this last question. Sorry, Ketan, you wanted to add something?
No. So what happens in this usually following post-HA strictures, if they are not amenable to balloon dilatation, usually it is seen that it is one of these sides is more dominant stricture than the other side. And then it goes into atrophy hypertrophy complex. and you may able to do a resection of one side with a drainage of the other. What is Mr. Dixon's view on this?
My view is to ask you because I'm a pancreatic surgeon and you're a liver expert.
But this is
it's a really good point because with a lot of these situations, there's not a one size fits all.
Exactly.
And it goes back to what we've both been saying, which is individual multimodal therapy. And if you keep the principle the same, which is biliary drainage, how you achieve that principle comes down to your own preference. So I think it's a really good point.
The last question is more of an ethical question, probably. It says he asks about a 93-year-old male with periampullary mass causing CBD and pancreatic duct obstruction. How to proceed? A 93-year-old. Well, that's probably an ethical question. Chetan, in your context, in the Indian context, how would you deal with that?
Sir, we would offer him an ERCP, and if there is a duodenal obstruction, we'd put a gastroduodenal stent.
I feel his age should not be a factor if the patient is.
If his ECOG status is good, yeah.
Yes, exactly. I think that should be how it should go. Right. So Praveen has the last question, and for our president.
So, what is your take on with benign biliary stricture diagnosed? These nowadays endoscopists are doing multiple stenting of the biliary tree. So, what is your take on that?
I was going to ask that same question.
Yeah, so I don't think that's a good idea for what it's worth. I think it comes back to where I think we have the luxury of doing a bit of everything, the surgery, the endoscopy, EUSE, RCP. So you're not trying to practice procedure-focused medicine. And I'm not being critical of our gastro colleagues. I think they do a fantastic job. But if you're getting to the stage of having to use multiple stents in the bile duct, firstly, I'm never sure which benefit that confers. These multiple plastic stents don't achieve anything in my view. You're much better with one SEM, so you've got a constant radial force to remodel the duct, or think about an operation. And I think even in a surgical unit where we do endoscopy, I think sometimes because endoscopy is relatively straightforward to book and it's easy to get the patient in, I wonder if sometimes we err on using endoscopy where for some younger patients, one operation at the start of their journey might be better. So I wouldn't favour multiple stents.
Actually, the need of putting more than 2 stents is an indication for surgery.
Yeah, that's a very good point.
Right. So thank you very much, gentlemen. I thank you for your time. Thank you for your expert comments and opinions and answering all these questions. I really appreciate your efforts from the RCPSG and the office bearers of ASI. John, concluding words from you, Vice President of RCPSG.
Thank you, Prabal. I sincerely thank our esteemed speakers, Mr. Ewan Dixon and Dr. Chetan Kantaria, for taking time out of their very busy schedules to share their expertise with us today. Your insightful presentations have provided invaluable knowledge on benign biliary obstruction, and we truly appreciate your time and dedication. A special thanks also goes to you, Prabal, and your team at ASI, and also our management team at our college for your hard work behind the scenes in making this session possible. Your efforts in coordinating this event has ensured a smooth and enriching experience for everyone. To our audience, thank you for your active participation. We hope you found this session informative and valuable. We've covered key aspects of diagnosis, management, and treatment approaches in benign biliary obstruction, emphasizing the importance of timely intervention and multidisciplinary care. I encourage you to apply these insights in your practice and stay updated with advancement in this field. A recording of this webinar, along with additional materials, will be available on the YouTube channel of the Association of Surgeons of India. We would greatly appreciate your feedback as it helps us improve future webinars. Once again, thank you all for joining us. We look forward to seeing you in our next session in 3 months, where we'll be discussing malignant biliary obstruction. Thank you very much.
Thank you very much.
Thank you.